questions and provide guidance for your practice during the COVID-19 pandemic. My name is Kelly Wesselman, and I'm a rheumatologist in Georgia. I'm a member of the ACR's Board of Directors, and I'm also the chair of the ACR's COVID Practice and Advocacy Task Force. This task force has been focused on providing guidance and resources to support all of our ACR and ARP members in managing their practice during this pandemic. We have posted comprehensive resources on the ACR's website relating to issues around telemedicine, drug shortages, practice economic support, and policy updates. You also have the ability to reach out to the ACR through the website with individual questions or concerns. The ACR has also continued to advocate for rheumatologists and rheumatology professionals through this time. We have 5 main advocacy priorities that we have focused on during the pandemic. Just to review, we were strong advocates for HHS CARES Act funding for rheumatologists, and we are continuing to advocate for enhanced financial support in the next round of stimulus funding. In particular, we are working for more direct financial support to preserve vulnerable specialty practices. Second, the ACR was a vocal advocate for audiovisual and audio-only payment parity with both CMS and private insurers, and this will remain an advocacy priority. We also continue to advocate for regulatory policies that reduce the burden for telemedicine. Prior to the pandemic, the ACR was instrumental in advocating for E&M reimbursement changes that will yield an average 15% increase in rheumatology office visits starting in 2021. We have continued to work to ensure this increase goes into effect as scheduled, even in the current turbulent climate. Fourth, the ACR developed documents concerning provision of services during the pandemic, including guidance around providing office-based infusion services, as well as a statement about home infusion, principles for decision-making concerning in-person urgent care versus virtual non-urgent care, and guidance for how to talk to patients who have questions about how and when to access rheumatology care during the pandemic. All of this is on the ACR website with the resources I mentioned previously. Finally, since hydroxychloroquine and chloroquine were mentioned as potential treatments for COVID patients, the ACR worked with patient groups, including the Arthritis Foundation and the Lupus Foundation, to ensure patients can continue to have access to their medications. The ACR remains in constant communication with the FDA to discuss access to needed therapies for rheumatic disease patients. Tonight's town hall will focus on what we have heard from our members in focus groups held around the country, which are the top 3 practice-focused issues and concerns currently. These are telemedicine, both during the pandemic and post-pandemic, how to safely reopen clinics, and how to counsel patients with rheumatic diseases as states are reopening. And finally, HHS CARES Act funding and concerns around future potential audits. So I'd like to now introduce the participants, the panelists that are joining me tonight as we work through some of these questions. First, we have Sean Fahey, who joins us from North Carolina as a rheumatologist there and a member of the COVID Practice and Advocacy Task Force. We have Christine Stamatos joining us from New York, who is our president-elect for ARP. Chris Phillips is joining us out of Kentucky, also a member of the task force. Aruni Jayatilaka is joining us from Pennsylvania. Angus Worthing, also a member of the board of directors with me, is joining us from Washington, D.C. Virginia Reddy is joining us from Dallas, Texas. And Caleb Michel is joining us from Nebraska. Thank you all of our panelists for being here with us tonight. So at the time of registration for this town hall, members had the ability to submit questions regarding the future state of telehealth for rheumatology, return to work guidelines, and HHS audit concerns. In addition, over the past several weeks, the ACR has gathered data through a series of focus groups and surveys to find out our members' biggest areas of concern and questions. Many of those questions will be addressed tonight during this presentation. You are also encouraged to please submit questions throughout tonight's presentation using the Q&A box that you will see on your screen. We will answer as many of the questions submitted through the Q&A box as time permits. However, we will not be taking any verbal questions during today's webinar. and your microphones will remain muted throughout the presentation. I will now ask Sean Fahey, rheumatologist in North Carolina, to ask our speakers questions that we received from all of you via the registration link. Please don't hesitate to continue to ask questions using the Q&A box as we go along. Thank you. Sean?
Thank you, Kelly. The first series of questions we will address are on telehealth. We have ACR volunteers Chris Phillips, Aruni Jayatilaka, and Caleb Michaud here to answer questions. The first question I will pose to Aruni. What are the best and safest uses of telehealth, and are new patients being seen via telehealth?
Thank you, Sean. There's definitely a reasonable amount of published literature on telerheumatology, and much of it focuses on patients with inflammatory arthritis, especially rheumatoid arthritis, as well as positive patient and provider experiences, more so than disease activity-related outcomes. There is promising new information on remote monitoring of gout with good outcomes in terms of gout flares, but unfortunately we don't have a lot of information yet on connective tissue diseases like lupus and scleroderma. From my personal experience, patients whose conditions are in a low disease activity state without frequent flares can be safely monitored remotely, and many of these patients were not coming in for in-person visits frequently prior to COVID-19, and were also capable and comfortable self-monitoring their illnesses, which seems to translate to less frequent in-person visits. New patients are definitely being seen by telehealth. We can all recognize that this is not an ideal situation, but it's necessary for us in order to allow people to access care and avoid exacerbating the already limited availability of all had experience with. The thorough and comprehensive history is also invaluable.
All right. I'm going to ask you one more question, if that's okay. Does it seem patients are comfortable with getting treated or diagnosed through telehealth?
Sure. I think this is probably very variable depending on the patient and the provider, as well as the condition in question. My own experience has been that many patients are comfortable with diagnosis and treatment via telemedicine, especially those who actively seek out and choose to participate in telemedicine appointments, even the new patients. My approach is, I'm sure, similar to that of other rheumatologists and other clinicians, which is that I try to engage patients, especially the new patients, in a discussion of the limits of telemedicine and instances in which in-person evaluation is more important or necessary. But I think Caleb also has a perspective on this.
Yes, thanks. I surveyed about 2,000 of our patients and Forward, the National Data Bank for Rheumatic Diseases, and we asked from March through May about their experience with telehealth. And first of all, more on average, about half of participants had one or more telehealth visits between March and May. Surprising to me, 72% were somewhat or very satisfied with their appointments. What we found was that the lower the education, this was associated with the lower satisfaction with those telehealth visits. On the qualitative side, the patients for the most part reported that they liked telehealth visits, that they were safer, less travel time, and they continued access to care, which is most important for many of them, just mainly access to their medications. But they communicated that there was this overall perception that telehealth visits were probably less useful than being in person overall.
Great, thank you. I'm going to turn it over to Dr. Phillips for the next question. Chris, how long will telehealth and telephone be reimbursed the same? And will telehealth continue to be supported by the government as well as private insurers? And when will Medicare or private insurance stop covering telemedicine payments?
Thanks, Sean. So to set the stage, we need to understand that CMS approved payment parity first for audiovisual visits and retroactively for audio-only visits. As things stand, this parity will be maintained through the end of the declared public health emergency. Obviously, it's uncertain when that declaration will be over. The current end date is July 25th, but HHS has signaled it's likely to be extended. We're aware there's a lot of discussion in Washington regarding changes to telehealth coverage. that could be extended after the public health emergency is over, I think a lot of us are hopeful that payment parity for audio-visual may persist, although audio-only parity may be a little bit of a stretch. We also need to recognize private payers are making their own policies. The majority, especially the large payers, are following CMS in audio-visual and a lot in audio-only payment parity. A lot of them have set arbitrary end dates to these policies. We have heard concerns from members as these dates approach for some of their local payers. What we've generally been seeing is that as these end dates are approaching, they're being reviewed and extended. And in general, we expect those extensions to continue, generally following CMS timelines. As far as ongoing use of telehealth, ACR has actually had conversation with at least one large payer in recent weeks who did actually want to discuss with us what it would take to get our members to continue employing telehealth as a means to serve their members. And we know that even before the pandemic, there was discussion at CMS about how to expand telehealth. So we know there's discussion about how they might continue relaxing site of care restrictions and types of services that are covered long-term. So we don't know exactly how many of the regulations that have been relaxed may remain relaxed, but we do foresee an environment where payers are going to try to continue facilitating telehealth in some fashion.
Excellent. I'm going to send one more in your direction, Chris. When and will we be able to use telehealth across state lines after the health emergency ends?
Sure. Well, the short answer is yes, but I think folks need to be planning for that now. So understand that CMS policy waivers allow cross-state practice, but practically speaking, state-level policy really governs what you can do. So HHS has directly asked each state to remove any barriers to cross-state practice, but state responses to that have varied. Hopefully those of you who are currently practicing telehealth across state lines have looked at those regulations in the state where the patient resides. Many states are allowing cross-state telehealth with very minimal or basic paperwork. There are some states that are not requiring paperwork. There are a few states that are still precluding it or that may require full licensure. And we know that there are some states where there are other limitations, for example, prohibiting new diagnoses from being rendered. We should generally expect that once the emergency is over, prior licensure requirements probably will resume. So in a lot of states, that would be full licensure. We know that there are some states that belong to an interstate licensure compact through the Federation of State Medical Boards to streamline applications. Just in my own personal practice, I'm currently in the process of applying for full licensure in the states surrounding me where my patients reside in anticipation of that situation.
All right, thanks for sharing that. One more for you, Chris. In terms of HIPAA, how long are we going to deal and how are we going to deal with waivers?
So I think that probably is one of the biggest questions that we don't have a good answer to. We need to recognize that there's a tension between the relaxation of those waivers and the ways that it's allowing us to take care of our patients versus the need for security for the patient records. So we do need to be sensitive to those privacy concerns when we think about long-term use of non-HIPAA compliant platforms. Right now, I think that for the most part, our members should be comfortable taking advantage of the relaxed regulations in the name of keeping our patients out of the healthcare setting, especially if you're in a place or a time when you're seeing an increased incidence of COVID-19 activity. Hopefully, most of us who are listening have at least one HIPAA compliant platform that we default to. If you don't, I certainly would advise that. And ideally, we have our staff trained as well as possible to troubleshoot access to that platform for as many patients as possible. But it's obviously very helpful to have platforms like FaceTime to fall back on. The ACR does have a new position statement on telemedicine, which does support appropriate protocols to protect security and integrity of patient information while balancing the need to access telehealth services. I think in general, we should assume that these waivers will last for the duration of the emergency, but this is a great question beyond that, and I don't think we have a good answer as yet.
All right, thanks for sharing all that with us. I'm going to go back to Aruni for the next question. How can a joint exam be performed effectively with a video visit?
If I had the answer, I'm sure a lot of people would be looking to me for this. But for myself, performing exams so that I can objectively evaluate a patient's joints requires basically almost ideal conditions, meaning the lighting has to be good, the positioning of the camera, including the patient's ability to move the camera, the internet connection to avoid pixelation and skips, which we've all been frustrated by. And even with all of this, because most of the telemedicine visits that I do are via smartphone, I'm basically best able to evaluate the hands, wrists, and elbows, especially for range of motion and maybe synovitis of the hands and wrists. I've seen demonstrations of evaluation of the spine and lower extremities. In fact, there was a recently published orthopedics just overview of the general musculoskeletal exam in the literature. But most of these tend to assume a computer camera rather than a mobile phone, and for myself are not practical for use. I think Caleb has a more kind of objective stance on this to share.
Objective meaning like maybe it can't be truly as effective, but so a couple of quick comments from the patient perspective. You know, basically if you want to reduce the amount of time that you're spending with the patient, so you're not just turning your telehealth visit into an IT call, as having your staff or other folks help prep the patient as much as possible in advance. And that means if you're going to be thinking this is going to be happening for some time, getting some pictures or video of the joints that you're interested in on the same lighting each time, so they can be a little bit more available for comparison, and have that ready in advance as much as possible. I know it's not easy to always do that, but it does help at some level. We have a paper coming out, hopefully by next month, as a follow-up on how to do the ACR RA disease activity measures that were recommended by the ACR, how to do them over telehealth. For the most part, when it came to this question, we were just basically looking at these measures being done by the patient. So patient self-examination with guidance from the physician along the way or from other staff. But we found that when the research shows that patients actually can be very good if they were given the proper education and training in advance. Since this pandemic didn't give us much warning to do this training, it's a lot harder now. But the thinking is that we don't know how long this might be lasting, and that the sooner we can get some of these materials out, the better it will be for all of us for getting these joint counts done.
All right. Well, we look forward to reading more about that. Thank you. One last question for our panelists. Everyone has been struggling with staffing to schedule and teach patients to do televisits, plus try to get them onto the platform and ready to go when the provider is ready. Aruni, any workflow suggestions?
I would echo that it's definitely a struggle for all of us clinicians, and perhaps those who have good workflow suggestions or who've been using telemedicine for longer than the rest of us should post their suggestions in the chat for others to see. In order to effectively perform video visits, what I found is that depending on the number of providers involved, you need staff specifically to dedicate a few minutes or perhaps more than a few minutes to instruct patients on how to set up and use your preferred interface. Sometimes it needs to be the family member of the patient. And then ideally to give them the link for the next day's appointment so that they can just check in at the appropriate time, at which point your visit prep can be done. But again, I think this is an ideal setup and not really a reality for many clinicians. But without a dedicated setup, I end up converting many televisits to audio only because video is very difficult to set up on the fly. Where I work, we don't mix telemedicine and in-person visits as well, so we don't get backlogs of patients in person. But I think probably Chris also has a different perspective on this from his practice.
Yeah, I'd agree with what Aruni said. In general, in our practice, we have the staff pre-call the patient the day before. That's also when they're screening for infection symptoms and offering or suggesting to convert the visit to telehealth if it's appropriate. As much as possible, they are troubleshooting the technological platform, figuring out if that can be made to work successfully, sending the link to log in, as she mentioned. And then typically the day of the visit, the staff is actually calling them back again beforehand to prep the charts, look at the medication list, et cetera, do a final check on compatibility and making sure that, that it works. In my practice, just in private practice, we are currently about 1/3 telehealth, 2/3 in person, and we do just mix and match them through the course of the day, and it's worked out okay for us so far. The more comfortable my staff has become with the platform, the easier it's been to get the patients onto it.
Excellent. Well, we all appreciate the knowledge that all panelists have shared with us so far. At this time, I'd like to turn it over to Christine Stamatos for any questions that have been submitted in the Q&A.
Hi, Sean. There is one question. It's regarding billing. When billing is based on time, can the addition of time used for charting, lab review, chart review, etc., be added to the direct discussion time with the patient?
Chris or Angus or Rooney, anybody want to chime in on that one?
I think the answer is no, but I'm not 100% sure of that, unless anyone else has any better knowledge about that.
I think there's a difference between video and audio. My understanding is that you can add those tasks into the time for billing and audio, since those are mainly based on time, but I don't think you can for video.
That's my impression.
That's my understanding as well.
Can I add to that?
Sure.
So I recently had a call. I'm sure all of you have had these calls. It started out as a telehealth with a video, and it was working fine. And 10 minutes into it, we lost video and had to go to audio. And I wasn't sure how I was supposed to bill that. And so I billed it as a video. It doesn't really now matter because there is a parity between the two, but even still, they saw that I wrote in my note that it had changed over, and my billing team said I had to give the number of minutes that were video and the number of minutes that were audio and describe that at the bottom of my note.
That's a lot of documentation.
I've heard this question a lot, and there is no guidance I'm aware of from CMS or other payers about this, except I think in general we are doing our best to use our best judgment about whether most of the visit was video, for example, or not.
Someone did add in, the recent rheumatologist suggests the above can be done, is what was written therefore incorrect. So they're saying that you can add all those times together. There was something in the rheumatologist. Does anyone know about that article?
I did not read that article. Any of the panelists have a chance to look through that?
I think that's something that we can further investigate with the ACR coding experts, and then perhaps post that on the website.
Excellent. Yeah, I think using the ACR coding resources is probably the best bet in a complicated case like this. Okay. Thanks again to all of the telehealth panelists who contributed. Our next set of slides are on returning to clinic. We are lucky to have Angus Worthing and Virginia Reddy with us to help share their knowledge. The first question, what are the best or recommended practices for keeping our staff and patients safe while reopening? I'll throw that out to Virginia and or Angus.
I will go ahead and start with that one. So the ACR has recently published a document on the ACR website addressing exactly this question, and you can find it at rheumatology.org/announcements. First of all, when we are thinking about reopening clinics, it is important to think about the local conditions, including particularly the current community prevalence of COVID-19, as well as clinic access to adequate PPE for all employees and providers. And there are, in the document there, we have outlined a number of simple measures that involve physical changes to the clinic and to clinic flows. And these are things like making sure your waiting room setup enables patients to be at least 6 feet apart. Consider having patients check in from their cars and wait in their cars until you have an exam room ready for them. Make sure that you set up your exam room such that the patient and provider can be at least 6 feet apart at all times, except during the physical exam. And requiring all patients to wear a mask and providing masks to those who arrive without masks and really insisting that they wear them. These measures require some forethought and organization and adjustment of our usual clinic practices, but are very simple to implement. And in general, the public is getting used to these type of measures in any public space, and for the large part has been very accepting and appreciative of these changes in our clinic. In Dallas, where I practice, we are now in the middle of a major COVID surge. And what we have found particularly challenging, and what I want to focus a little bit more on in answering this question, is on how to educate and reinforce the importance of social distancing measures for our staff, especially when they're on break at work and also when they are away from work. And we're a large practice. We have 20 physicians and we have about 120 employees. And so far we have had approximately 10 employees who have developed symptoms and tested positive for COVID-19. So unfortunately, when there's this much COVID being spread through the community, employees will have exposures through other family members or through their own activities, such as going to restaurants, unfortunately bars, happily those are now closed in Texas for the moment, or they have other social outings with their friends. And we felt that we had done a lot of education amongst our employees about self-monitoring for symptoms, about the need for social distancing, both at work and at home. But we had employees who came to work for several days despite the need that they had symptoms. And so we realized that we needed to do a better job with educating our own employees and screening our own employees. We also had, unfortunately, multiple employees who are good friends and enjoyed eating lunches together. And we had one office where 5 out of 6 employees who worked together developed COVID. And so we have learned a lot from that. Fortunately, all of them, including the physician who developed COVID, have recovered, and most of them are back at work. Over this past 4 to 6 weeks with this current surge, we've had probably 10% of our staff out at any one time quarantining because of exposures largely at work, but also at home. And since then, we've redoubled our efforts at employee education. We have basically removed chairs from the break room so that it's almost impossible to sit and eat lunch close to each other. We've posted signs everywhere. We've done email blasts repeatedly, an email campaign to remind our employees to continue using social distancing. And basically, I just would really strongly urge you, in addition to all the physical measures and providing PPE and thinking about staggering patient visits, to really think about educating your employees about signs and symptoms of COVID-19, the importance of not coming to work if they're having symptoms, and of masking regularly at all times, including with their work colleagues.
Wow, thanks for sharing that about your practice. It's certainly something everyone who sees patients is going to have to deal with if they see a surge in their area. I'm going to move on to the next question. What are the best practices for maintaining social distancing with several providers and/or trainees in the room? Angus?
Thanks, Sean. Hi, everybody. So the 2 main principles are to limit the number of people in the exam room and limit the amount of time that people spend together in the exam room. So when I'm, and in my group and many people's groups, I think, we're asking patients not to bring anybody to the visit. And of course, on a case-by-case basis, exceptions are made for caregivers or family who can help either with communicating or the patient following through on the treatment plan. Also, performing procedures when often medical assistants are in the room. Sometimes we can limit that and do a procedure solo without the help of the medical assistant. About training, I actually haven't had the chance to teach during the pandemic because of our change in workflow. And I want to thank Aruni for giving me some of the following tips I'll just mention from her. This is a good opportunity for trainees at all levels to have an unsupervised history and physical, if time and space allows. Ideally, some tips relating back to what I mentioned, not to be typing in the room, to save that for later time, and also to minimize time spent, also minimize having to clean computers. They can also present to you outside the room. While we're in the room with trainees, they can, we can all do social distancing as much as possible, partly by teaching the patient and the trainee at the same time, minimize the amount of time together. You can stand next to the patient's side and narrate back key physical exam findings to the trainee. And finally, consider keeping your door open, especially if you can increase privacy with a curtain or with a noise machine in the clinic, or if it's in a place in clinic where you won't have foot traffic nearby.
Great. Virginia touched on this next question a little bit, but I'm going to ask you all to expand a little bit more. In clinic, how can we address when employees need to stay home or be sent home if they have some symptoms which might be COVID-19 related, or if they have a known exposure? And when can an employee who previously tested positive or had presumed COVID return to work safely?
Sure, I'll take this one, Sean. As Virginia noted, if staff or patients have symptoms consistent with COVID, they should stay home or go home if they're at the office. Exposures can be covered by the CDC. There's a screenshot, or there's a link that I can send out in the Q&A about exposures. Essentially, if a healthcare provider has prolonged close contact with somebody who has confirmed COVID-19, then they should be excluded from work for 14 days after that last exposure. Two quick definitions. The amount of time that prolonged means is defined as 15 minutes, but any amount of time in an aerosol generating procedure, or that, you know, using your judgment, you think is prolonged close contact, you can call an exposure. If healthcare personnel are not wearing a respirator or face mask, number one. Number two, if healthcare personnel is not wearing eye protection, if the person with COVID-19 was not wearing a face covering. And three, if the healthcare provider was not wearing all the recommended PPE during aerosol generating procedures. So that covers exposures if somebody's exposed 14 days out of the office. About returning to clinic after recovery, staff coming back or patients coming back in for an office visit after they've had COVID-19. ACR guidance, as was referenced, published last week, recommends that staff or that folks can come back based on CDC recommendations for discontinuation of precautions. Two strategies: the test-based strategy people might be familiar with, and also the symptom-based strategy, a lot more accessible. Test-based strategy is after 2 negative nasopharyngeal swabs at least 24 hours and people's fever has resolved without the use of antipyretics and their respiratory symptoms have improved. The symptoms-based strategy, which might be used more frequently if testing isn't available, individuals may return when they have been afebrile without the use of antipyretics for a minimum of 72 hours. Their respiratory symptoms are improved, and then they have at least 10 days since the onset of their symptoms. There is note about asymptomatic patients, which is common. They may return 10 days after their first positive test, assuming they don't develop symptoms in the interim, or following 2 consecutive negative RNA tests. So that's a lot of information there about CDC recommendations. I'm going to hand it over to Virginia to talk about her clinic experience.
Thank you, Angus. So we are using those CDC recommendations, and in our clinic, people who have returned have been following the symptom-based strategy. I think that what we have found challenging is really deciding who's had what kind of exposure and who needs to be quarantined. And every situation is different. And what we've ended up doing is we have sort of two people who are running those types of decisions. So it's a two-person committee. It's our nursing director and our practice manager. And anyone who has an exposure possibly at home or at work describes the exact nature of the exposure, and then those two people each independently decide, do I think this person needs to be quarantined? And if either one of them is a yes, that person is quarantined. And we've been pretty conservative about it ever since our initial disaster that occurred in one of our offices. And that seems to be working so far. The other thing that we have found useful is consulting with local infectious disease colleagues. And we've also been in close contact with our county health department. And the county health department actually has advised us on how to notify patients and whether it's necessary to notify patients when they have come to an office where subsequently we've had an employee test positive. And our county health department has advised us to notify all of those patients, which we have by email. And to our knowledge, we have not had any transmission from any of our employees to a patient or vice versa that has occurred as far as we know. But all of it is, as this entire thing has been, a moving target. And I would just recommend that you use your local resources as much as possible to help guide these kinds of decisions.
Yes, thanks both of you. I will echo that the recommendations seem to change frequently. So keeping in touch with the CDC recommendations and your local recommendations is imperative as we all negotiate these challenging times of providing care, but keeping our staff and our patients and ourselves safe. All right, let's move on to the next question. What are the best practices to efficiently combine telehealth with in-person visits in order to maintain our revenue and keep the doors open for our patients?
Sure, I'll take this one, Sean. I'll go first anyway. Very briefly, the workflow efficiency problem with telehealth was addressed earlier by Aruni and Chris. 4 things I'd recommend. Number 1, have a backup for telehealth. I use Doximity. Other people can use other things. Number 2, staff assistance is really key, as was mentioned before, confirming the cell phone and the email and trying to drive patients onto the site and the platform successfully, but also having staff maybe in real time reschedule patients either for lunch, if it's morning, or the end of the day, if it's just totally not working, or deciding to switch to a phone call, as most of us have done. And then in our workflow, a lot of my partners and I have realized that it's very hard to go back and forth during the day between virtual visits and in-person visits. And so if it's possible to bunch up the virtual visits, you get more of waiting room flow going, and then switch back to in-person visits if possible, or bookend an in-person clinic at the beginning, at the end with virtual visits. Also, if community transmission is low in your area, patient characteristics are, you shouldn't have a problem inviting people into the clinic for in-person visits if necessary for the care that they need, or the diagnostics that they need, x-rays, ultrasound, injection, some in-person physical therapy, followed by virtual physical therapy follow-ups, labs, clinical studies, and these things all can help drive revenue too. Also hand over to Virginia, who also has her own experiences.
Thanks, Angus. I agree with everything that he just said, and also wanted to echo the recommendation for using Doximity as a backup. I actually did a video call on Doximity this morning when my primary platform failed. And what I've found works best for me is to do telehealth as a full day from home, and that frees up those patients in terms of patient flow in the clinic for the providers who are seeing patients in person that day. And that helps us reduce our total volume in any one day in clinic. All of our partners have different approaches to this. I have one partner who is doing telehealth in the office, and he has a nurse practitioner seeing new patients for him. So he'll do 2-3 telehealth visits, he'll pop out and meet a new patient, do an exam, and then continue the telehealth flow. So there are a lot of different ways to work it, and I think all of us just need to be flexible and continue to try to optimize as the conditions keep changing. But I do think telehealth is going to be here to stay for a while, and we need to learn how to incorporate it efficiently into our practices.
All right, thoughtful advice. Thank you both for that viewpoint. Let's go to another question about patient care that we're all struggling a little bit with. How long do we need to hold off immunosuppressive medication after our patients test positive for COVID-19?
Sure, I'll take this one, Sean. I know that all of us on this town hall have been figuring out how to do this almost on an individual basis based on patient characteristics and our review of literature and in talking with colleagues. I've had a very small number, 5 people restart DMARDs, and they've done well. But just today, I'm grateful for the ACR to have come out with guidance about this question. It's not yet published, but it was posted on the website today, again, at rheumatology.org/announcements. You scroll down to COVID-19 clinical guidance summary for adult patients with rheumatic diseases, and it's updated with this basically 2-pronged approach. One prong for uncomplicated patients and another for more severe cases of COVID-19. For patients who have had uncomplicated COVID-19 infection, mild or no pneumonia, treated in the ambulatory setting or via self-quarantine, you can restart rheumatic disease treatments like DMARDs, immunosuppressants, biologics, JAK inhibitors within 7 to 14 days of symptom resolution. So we're basing it on the timing of symptom resolution. For patients who've had positive PCR tests for SARS-CoV-2 and are asymptomatic and remain asymptomatic, you could consider restarting medicines 10 to 17 days after the PCR test was reported as positive. And the task force had a high degree of consensus on this. Then for more severe COVID-19 related illness that has not been treated at escalated care from the ambulatory setting, for example, to hospital or ICU, these need to be made on a case-by-case basis. And there was also a high degree of consensus in the task force members about this. So again, thanks to the ACR task force, I was not a member of this, but who has come out with this. And you can see this again at the website. And also the guidance document is in queue for publishing, the manuscript, that is. Thanks, Sean.
Thank you, Angus. Another great piece of guidance from ACR that's available on the website for our members. Let me turn it over now to Christine. Any questions that have been submitted in the Q&A?
Yes, actually, the first one has to do with telehealth, but it also has to do with trainees. So I wondered if Angus could talk about how you're working in trainees with regards to seeing patients virtually, if you don't mind. We didn't touch on that in the first telehealth section.
We did a little bit, and thanks to Aruni for basically the concepts are to minimize number of people in the room, minimize the time spent in the room. So trainees presenting outside the room.
No. I was specifically trainees doing a virtual visit.
I apologize, misheard you. So that is something I have not figured out yet, as I've just been struggling with my own clinic. I might pivot to Aruni, but I know that many programs allow for multiple people to see the same person, or potentially the trainee could have an account, do a virtual visit, and then present either outside of that visit or with a group visit, if it's allowed by the platform. And I think I can say theoretically this would work, but I haven't tried it myself. Have other folks on the call, have other panelists done this yet?
I can add my experiences, and it has been a bit of growing pains all around. But basically, you have the options of direct supervision, both for audio or video. So many of the platforms we use allow for a third person to come in. So that would be direct supervision of a video encounter. You can have, if you have unlimited time, have faculty or supervisors listen in on phone calls. And then there's indirect supervision, where the faculty or supervisor is available and hopefully discusses the case afterwards, but isn't personally interacting with the patient. Both of those are allowed under the ACGME, but I guess without getting into the weeds too much, it poses a different scenario for billing. So both indirect and direct supervision are allowable, and perhaps if you're thinking about this, you might think of using that with your trainees in their second and third year rather than with your trainees in their first year of fellowship.
Okay, I didn't get any feedback as to whether that was that answered the question well enough. So we're going to move on to another subject. This is more logistical, and that is regarding PPE. Someone is asking, what PPE do you commonly use? And in the same tone, also, if you could comment on the use of air purifiers.
I would be happy to speak to PPE as we are in the situation we are in. We are following CDC guidelines, and that includes all staff members wear at least a surgical mask, and if you're going to be within 6 feet of a patient, we are now requiring everyone to wear a face shield or eye goggles, some sort of eye covering. Because of the prevalence in our community, and because we actually have adequate supplies of PPE, we are also asking any of our providers who are in the room with the patients for a prolonged period of time to wear N95 masks. So most of our staff are wearing surgical masks, but our physicians and other people who provide direct patient care are wearing N95s now, as well as either face shield or eye goggles.
All right, I'm sure there's other great questions, but I want to leave enough time for our third topic. So I'm going to push us forward to the HHS relief funds and audits. Chris Phillips has been very involved with this, so he's going to read a statement about our current level of understanding, and then I have some questions that were proposed by the registrants.
Sure. Thanks, Sean. So as we all know, the CARES Act provided funding for provider relief through grants. Most of us saw these funds deposited into our accounts in early April, and we were required to attest to receiving the funds and agreeing to comply with certain terms and conditions in order to keep them. Unfortunately, the terms and conditions and the frequently asked questions on the HHS website left enough unanswered questions that some of our members were either unwilling to accept the funds, or those of us who did accept them remained somewhat uneasy about them. The ACR has been in contact with HHS, highlighting our concerns about reporting and about audits of the money. In our communication with HHS, and I was on a phone call with some of our staffers, we did learn that they generally plan to be fairly flexible with the auditing and reporting requirements. All of those reporting and audit efforts are basically to ensure that we're using the funds as intended, which is for healthcare related expenses and or loss of revenue, and not for other expenses like buying a boat or a car. Obviously, they don't put that in writing, what I just said, but that's what they've told us off the record. They essentially want to make sure that the funds are being used to help keep practices open and allowing us to continue caring for our patients. There have been some updates since the initial release of those funds, and in the most recent FAQ on their website, they have actually said that recipients are not going to be required to report to HHS on a quarterly basis as we initially thought. Instead, the HHS Office of Inspector General is going to monitor for any fraudulent activities and may contact recipients for any necessary reporting documentation. They have not clearly stated what that documentation would be, although in general we believe that that would probably consist of tax documentation, and or some other proof of loss of income. They do continue to update their guidance weekly. We have staff who continue to be in communication with them, and we're doing our best to kind of interpret what they're telling us. And we would encourage members to reach out to ACR advocacy staff with any specific questions.
All right, thanks for that overview. I know there's still some unknowns and gray areas that HHS has been unwilling or unable to fully clarify, but a couple questions came up. Hopefully you can share a little insight. First off, what reporting exactly is required related to the HHS relief funds, and how do we do this reporting? And do we need to do any quarterly reporting about expenses and how the stimulus is being spent?
Sure. So this is a great question, and as I alluded to earlier, unfortunately, there's not a great answer. We know that the initial terms and conditions for the funds did require the recipients who received more than $150,000 in aggregate from the various responses, coronavirus responses, to submit quarterly reports. And the first of those reports would actually have been due just last week. But again, as they've updated their frequently asked questions, they've now said that that is not currently required. They have stated that they intend to develop a report containing all necessary information for providers to comply with their requirements. We've not seen such reports as yet. And they have said that they will notify recipients of applicable audit requirements in coming weeks. So unfortunately, there is still a lot of unanswered questions about how they are going to ask us to account for these funds. In general, what I would advise practices to do in consideration of the above is basically keep a really detailed ledger of all of your COVID-related expenses. HHS's website and their frequently asked questions does give examples of some of those expenses, obviously supplies that you purchase to respond to COVID, workforce training that you do in relation to that, and other reasonable expenses, as well as working with your accounting team to keep a reasonable ledger of COVID-related losses, either month by month or quarter by quarter. And HHS specifically says on their website that you can use any reasonable means of accounting to do so. I would advise that folks keep those documentation so that if or when there is an audit, you're prepared for that.
Great. And this next question is maybe even a little more pointed. One practice wants to know, how do we account for the HHS grant that was received? Should it be dealt with as income or a loan? If there hasn't been a loss yet, but fiscal year ends September 30th, how should all of that accounting and documentation be done?
Sure. So what we know for sure is that HHS's intention is that these funds be expensed during the public health emergency. As we've talked about earlier on this call, we don't know when that's going to end. If at the conclusion of the pandemic, providers have leftover relief fund money that they can't reasonably account for the expense of, they'll be asked to return those funds to HHS. There's not a penalty for that. And I know that's been a question some of us had earlier in this discussion. We received these funds. We don't know if we received not enough or too much. HHS's intention is use them in the meaningful way during the emergency. When it's over, if it's not been expensed, they plan to provide a pathway to return those unused funds. They've not, again, they've not laid out that pathway just yet. You do have to, again, attest to the terms and conditions about how to account for those funds. And an important point, so as things currently stand, those funds are considered taxable. It's felt that that's due to a drafting oversight in the way that the bill was put together. Much like the Paycheck Protection funds, where there was a bipartisan push to change that and get that righted, there is also a bipartisan push in Congress to change that and to make the funds not be taxable. So we're hopeful that that will be changed, although as things currently stand, it is considered taxable income.
Okay, more excellent information. Finally, a question about in an academic center, how can we find out if the rheumatology department or providers are getting any of the relief funds?
That's been a common question we've received as well. So HHS has posted on its website the names of payment recipients as well as the amount of payment. It's on their public website. They're also working with the Department of Treasury to reflect the aggregate total of each recipient has received on usaspending.gov. You know, there's no formal guidance requiring large teaching centers or healthcare systems to use those funds to maintain provider salaries or employment, which is obviously a concern for us. And for those who work for large, maybe even multi-site organizations, you know, those funds may have been received 2, 3, 4 rungs up the ladder from where you are. So that is a great question, and we do encourage members to ask their administration how those funds are being used. That's the best advice we can give at this time.
Okay, well, we want to be sensitive to everyone who joined the town hall and their time. So I'm going to turn it back over to Kelly Wesselman, and we're going to withhold any questions about the HHS funds, but please feel free to submit to covid@rheumatology.org.
Thank you, Sean. Thank you to all of you in the rheumatology community for your questions and engagement this evening. We appreciate your attendance. I want to give a special thank you to all of our speakers for their insights tonight. Our goal is really to assist the whole rheumatology community with clinical and practice recommendations during this difficult pandemic. Rest assured that the ACR will continue supporting practices both during the pandemic and beyond. And our COVID-19 Practice and Advocacy Task Force will continue to develop resources to help all of you address these challenges. You can access these resources by visiting the ACR website at rheumatology.org, or you can reach out with needs or any questions, especially questions that we didn't answer tonight, by emailing covid@rheumatology.org. Again, that's covid@rheumatology.org. Finally, the ACR wishes to thank our sponsors AbbVie, Amgen, Bristol-Myers Squibb, Gilead, and GlaxoSmithKline for their support of the ACR's COVID-19 emergency response initiatives. Thank you again to everyone who participated in this town hall. Again, please email additional questions to the ACR at covid@rheumatology.org. This recording will also be available on our website at rheumatology.org by the end of the day tomorrow. The ACR's promise is that we are here for you so that you can be there for your patients. Thank you and have a good night.